Alright, so let's talk about skin cancer for a minute. So in today's video we're going to be talking about skin cancer. And typically when we mention skin cancer, we obviously mean a malignant lesion in relation to the skin. And there's many origin of sites in regards to skin cancer. Some cancer in the skin can arise from the epidermis. Then some of them can arise from the dermis. Some of them can arise from the neural crest. But in today's video we're going to be talking about 3 types of skin cancers that are very common, by far the most infamous ones, and all 3 types of these skin cancers we're going to be talking about in this video originate from the epidermis. Okay? So now let's talk about that. So regarding skin cancer, before we go into each type of skin cancer, we want to talk about the risk factors of developing skin cancer. Obviously, you know that one of the ways or one of the risk factors of developing skin cancer is exposure to the sun. Especially here in Sardinia, where people are exposed to the heat and especially to the sun every day. So, and as you know, the sun consists of ultraviolet rays that it transmits. So a person who's exposed to ultraviolet radiation constantly every day for long periods of time with a maximum concentration increases the risk of cancer, because the ultraviolet rays from the sun, they tend to damage our cells, especially that of the skin. They damage the nucleus of our cells. That's why we have something known as melanin. Melanin, especially those that are darker skinned, they tend to act as a shield to protect the nucleus of the cells of our skin from the ultraviolet radiation. And even then, it's not enough, because some of the ultraviolet rays damage can affect the DNA. And as a result, we also have certain DNA repair mechanisms to undo the damage by the ultraviolet rays on the DNA. And if these DNA repair mechanisms failed, if we don't have melanin, like in the case of albinism, people that are albino, or people with a genetic disease like xeroderma pigmentosum, in which they don't have a DNA repair mechanism from the ultraviolet rays, then it is a high, almost guaranteed chance of developing skin cancer. So you can develop it from ultraviolet rays exposure, or genetics involved, or also associated with aging. Like people with squamous cell carcinoma, the majority of them are elderly Caucasians. Being with age, you're more liable to cellular damage. And also being white, you tend to have less melanin compared to a darker skinned individual. So fair skinned people naturally have more of a risk of developing skin cancer compared to African Americans, for example, because they have less amount of melanin content than African Americans. Are African Americans protected from cancer 100%? Of course not. But they have more of an ammunition or more of an armory to protect themselves from the ultraviolet ray damage that is induced from the sun. So the green basically tells you the general risk factors of developing skin cancer. And now we will go to the types of skin cancer. As we said before, the ones we're going to talk about in this video are 3 types of cancers that originate within the epidermis. Now let's revise back in previous videos the anatomy of the skin. As you know, the skin is divided into epidermal and then dermal layer, and then you got the subcutaneous layer, and then you got the fascia and the muscle, right? Let's start with the first layer of the skin, which is the epidermis. So this is the epidermis right here. And as you know, the epidermis is divided into 4 sublayers, from bottom to top. The first layer is the basal cell layer, right? And you remember the basal cell layer? From its name, it consists of basal cells, stem cells that differentiate into keratinocytes, nucleated cells. They will eventually ascend up and continue and fulfill its epidermal cell cycle throughout 28 days in order to become dead cells, or corneocytes, in the outermost layer of the epidermis. So that's what the basal cell layer from previous videos, if you remember. It consists of basal cells, and let's not forget, it also consists of melanocytes. It's going to be very important. And if you know melanocytes, they also produce this P for pigment. They produce the pigment known as melanin, so it can transfer it to the keratinocytes, so that they can transfer it to the keratinocyte cytoplasm to protect the nucleus of each keratinocyte from the sun. So we have a mother cell dividing into 2 daughter cells, basal cells differentiating into keratinocytes, and we have a melanocyte. Go up. Remember the spinous layer? SL for the spinous layer. And if you remember, some of the keratinocytes, they adhere to one another. They join together in a form of a chair, either this chair and this chair that we're going to sit upon, and we're going to ascend up together. And this chair is otherwise known as desmosomes. So you have desmosomes that join your keratinocytes together, and they give this and they give the form of a spine appearance for the keratinocytes. The keratinocytes may appear like a spine because of the fact that they are always held together by desmosomes, right? If you remember that, and if you remember the spinous layer, they also contain your Langerhans cells, which is by the color green. And then you go to the granulosa cell layer, which is, again, something we're not going to focus on, but from previous video, the granulosa cell layer was basically a layer in which you basically had keratinocytes secreting lipids, from the name granulosa. They were secreting lipids in between each cell, and they were secreting these lipids into the extracellular space. And this was acting as a water barrier, if you remember. Now, and then we go up to the top. We're not going to focus upon it, but that is the stratum corneum layer. This is the outermost layer in which you basically, at the end of it, you have a brick wall shaped cells. You have these corneocytes that don't have any nucleus. That's the keratinocytes. Their nucleus is shaved off. They became known as dead cells or zombie cells. They basically consist of keratin and filaggrin. And that's why in histology, really another name for corneocytes is also known as keratinized stratified squamous cells. So if you ever hear the term squamous cells in the skin, they also refer to keratinocytes or corneocytes. It's the same thing, all right? They're the same thing. Squamous cells, they refer to the keratinocytes or really the corneocells, okay? So that's the stratum corneum from the name itself. Consists of corneum cells making up your keratinized skin that's constantly shedding 500 skin cells per day. So those are for all the 4 layers of the epidermis. These are the 4 sublayers of the epidermis, or the layers that make up the epidermis. And we wanted to revise some of them because they're going to be important regarding the origin of each type of skin cancer we're going to be talking about in this video. Okay? So let's start talking about Let's start talking about briefly some of the skin cancers we're going to see in this video. Okay? So let's start with those 3. BCC is basal cell carcinoma. Then you have SCC, squamous cell carcinoma, and number 3, the most serious, the one with the worst prognosis of the 3, that is melanoma. Those are the 3 skin cancers we're going to be talking about in this video. And if you see all 3 types of these skin cancers, all right, their prevalence is different and their mortality rate is different. So let's think together which one is the most common type of skin cancer. All right, these are the most infamous skin cancers. But which of the 3 is the most common? Well, from bottom to top, melanoma is the least common skin cancer of the 3. Then you have the second most common, squamous cell carcinoma, by the prevalence. And then you have basal cell carcinoma, which is the most common type of skin cancer. And if a person were to develop skin cancer, then you hope that this patient at least had basal cell carcinoma. Because what we found out is that the mortality rate or the death rate is the lowest in basal cell carcinoma as compared to squamous and melanoma. So, let's summarize. Regarding prevalence, melanoma is number 3, then number 2, squamous cell carcinoma, then number 1 is basal cell carcinoma. Regarding mortality rate, they're opposite. Basal cell carcinoma is number 3, followed by squamous cell carcinoma, then melanoma number 1 in mortality rate going downwards. Okay? So we're going to just talk about that because that will affect the prognosis, right? And that will affect the treatment. Some types of skin cancers like melanoma, we don't rely on chirotherapy. We don't just rely on electricity. Regarding treatment for melanoma, there's a high risk of metastasis and you have to do excision surgery. You have to remove the tumor completely directly. And you have to do chemotherapy if you feel the tumor was extensive. But in case of things like basal cell carcinoma, you don't have to go through excisional surgery. Not necessarily. You have other treatment options as well. So this will determine your prognosis as well and your treatment options. So these are the 3 types of skin cancers we'll be talking about. We summarize what skin cancers are. We focus on the ones that come from the epidermis, which are those 3. Their prevalence and their mortality rate. And we talked about the risk factors of developing skin cancer in general. And we also talked about, before we go into details, we revised the anatomy of the skin. Specifically, the layers that make up the epidermis. So that we know these skin cancers originate from where. For example, melanoma originates from the melanocytes in the basal cell layer. They become abnormal, or what they call in pathology dysplastic, and they proliferate uncontrollably. Regarding squamous cell carcinoma, from the name, there is uncontrolled cell division of the squamous cells or the keratinocytes in the spinous layer. They uncontrollably cell divide and they give you malignancy. And then you have basal cell carcinoma, in which you have basal cells. And basal cells are basically practically cell dividing uncontrollably and give you basal cell carcinoma. So the origin is from the name, and you could get an idea where they come from exactly. Do they come from basal cells, or do they come from squamous cell carcinoma, or do they come from melanocyte? Okay? Alright, now let's talk about each type of cancer individually. Let's start with basal cell carcinoma, the most prevalent with the best prognosis, and really something that's practically is almost benign in nature. It is a malignant tumor, but it's practically benign because it doesn't mean it never, but it rarely, if ever, metastasizes. So regarding metastasis in basal cell carcinoma, it's very rare. It's very rare. So it's almost benign, but not exact. It's still malignant with a benign-like character, let's say. So let's start with basal cell carcinoma. Now regarding basal cell carcinoma, the clinical presentation is that typically a patient will come to you with a skin lesion, right? He'll come with you with skin lesion due to uncontrolled cell division of the basal cells. And the skin lesion may appear in a variety of sites, okay? The most common site in basal cell carcinoma is the nose, especially the tip of the nose. So you can see in a patient with basal cell carcinoma a lesion that's noticeable on the nose. It can be in other areas as well, in the cheeks, in the forehead, anywhere else, but typically in most patients with basal cell carcinoma, the nose is the most common site. You can see it on other places in the head or in the neck, but again, the nose is the most common site. And what is going to be exactly in the nose? Well, you see in this face right here. Well, in the nose, you'll see the presence of a pearly, meaning colored, like the color of a pearl, or reddish, a pearly colored plaque or nodule with telangiectasia at the center. So if you look at any picture of basal cell carcinoma, you might see a patient who represents to you with a pearly colored or a reddish colored or a pinkish colored plaque in the top of his nose, or a nodule, let's say, on the top of his nose, and at the center of this plaque, or at the center of nodule, contains your dilated veins, otherwise known as telangiectasia. And these nodules, these skin lesions, this plaque, this pearly plaque, or this pearly nodule, it has a liability of going through ulceration. Some of the superficial compartment of this nodule, it could ulcerate, and it can give to rise of a specific type of ulcer only seen in basal cell carcinoma, known as rodent ulcer, okay? And for people taking surgery, you know there's different types of ulcers. Diabetic ulcer, for example, arthritic ulcer, venous ulcer, also according to the cause. Here in rodent ulcer, this is a specific sign that's seen in basal cell carcinoma. Where did this rodent ulcer come from? Due to superficial ulceration of a pearly colored plaque or nodule in basal cell carcinoma. And where do we see this most commonly? In the nose, followed by anywhere else, maybe in the cheeks, forehead, neck, anywhere else, okay? This is the clinical presentation of basal cell carcinoma. And you will see this specifically in the most common subtype of basal cell carcinoma, and that is nodular basal cell carcinoma. You see, basal cell carcinoma, we can divide it into 4 subtypes, because this presentation, as I showed you, it is not the only presentation of basal cell carcinoma. There are 3 other different types of clinical presentation. That's why with basal cell carcinoma, we divide it into 4 subtypes, each with a different clinical presentation. But the one that is considered as a classical presentation, that is the nodular basal cell carcinoma. And you see this crown right here? This crown in my videos represents that this nodular basal cell carcinoma, it is the most common subtype out of all the 4. So nodular basal cell carcinoma is the most common type. The crown, compared to all of these. So that's number 1, followed by the rest of these, okay? So the clinical presentation, what I mentioned for the nose, is nodular basal cell carcinoma. Then let's look at other different types of clinical presentation of basal cell carcinoma according to the type. So we finished with nodular basal cell carcinoma. Let's talk about morphiform basal cell carcinoma. Morphiform means scar. It means you have a basal cell carcinoma that comes to you with the clinical presentation of a scar-like plaque. So you will have a plaque that is most commonly found in the trunks and in the extremities. Anywhere else in the body, let's say the extremities and the trunk, all right? And this plaque appears like a scar, you know? It appears whitish in color. So you have like this white colored plaque that resembles a scar, like this one right here. And the thing that's interesting about it, the thing that's unique about morphiform basal cell carcinoma is that when you look at this lesion, especially in pictures, it may appear flat, you know, it may appear superficial, but in reality, it's extensive. The lesion is extensive, meaning deep inside the skin, this lesion is actually going deeper. It's actually involving more of the skin, more of the epidermis. There's extensive tissue spread from the inside. So from the outside, this lesion may appear superficial. This lesion may appear not as extensive, but in reality, deep inside the cell, deep inside the skin, there is extensive spread inside. And that's what it is. There is one specific characteristic feature of morphiform. You have a scar-like whitish colored plaque with extensive subclinical spread from the inside. All right? It may not appear so from the outside, but it definitely is on the inside, okay? And this is what it looks like, or similar trait in most pictures. It appears sort of like a scar, okay? This is for morphiform basal cell carcinoma. So we will revise the 4 types of basal cell carcinoma. Which one has an extensive spread or spreads inside the most? Let's say spreads across the epidermal tissue. We're going to say morphiform basal cell carcinoma. Let's go to the next type. Superficial basal cell carcinoma. Now this is a specific type of basal cell carcinoma in which you can treat it by freezing. You can do cryotherapy for this patient. This is one specific type which cryotherapy can be indicated for. But let's go to the clinical presentation. What this superficial basal cell carcinoma looks like. Well, the clinical presentation is that you'll see this especially in the arms and in the trunks. You'll see that this individual will have a plaque. Again, a plaque. And this plaque is reddish and scaly. And you see this plaque right here in superficial basal cell carcinoma, instead of resembling a scar, it resembles the skin lesion that is typically found in eczema, or let's say contact dermatitis. So you might hear on the phone, a doctor might tell you that this patient has an itchy, reddish, scaly plaque. When you hear that description, you might think it's eczema. But when you go talk to the patient, when you get history, you say, wait a minute, no. This might not just be eczema. I take a biopsy and I found out, wait a minute, this is not eczema, this is basal cell carcinoma. And this is a problem too. This description right here, because in superficial basal cell carcinoma, because it resembles eczema in its clinical presentation as a reddish, scaly, itchy plaque on the arms and the trunks, like this picture right here, or when you Google, all right, because it resembles eczema-like, the problem is it can be mistaken for dermatitis. So a doctor might assume, this is a case of dermatitis, right? Or eczema. So he gives this patient a topical steroid. So after a couple of weeks, it hasn't resolved. It is still there as it is, right? So you assume what might be the problem? Well, if I'm suspecting malignancy, I do a biopsy, right? I can take a biopsy, like a punch biopsy of the lesion in the skin. And then I put it under a microscope and I just realize, wait a minute, this is a case of superficial basal cell carcinoma. So this is something to keep in mind as well. In order to make sure, in order to diagnose for any malignancy in the skin, take it as a principle. In order to diagnose for any malignancy in the skin, you don't diagnose it from the outside. It's not really a clinical diagnosis. It is a clinical diagnosis plus biopsy. You have to take biopsy to be assured of your diagnosis, okay? Before we go to the next type, something that's also special about superficial basal cell carcinoma, besides the fact that cryotherapy is indicated, besides the fact that it resembles dermatitis, another thing is the cause of superficial type is associated with exposure to arsenics, you know? And it's also associated with exposure to radiation. So if a person is exposed to radiation from X-ray, for example, is exposed to radiation from a CT scan, he is liable to develop superficial basal cell carcinoma if the skin was exposed to extensive radiation from imaging. So this is another thing to keep in mind. If you want to assume which type of basal cell carcinoma goes with a history of exposure to arsenics or exposure to imaging radiation, we think of superficial basal cell carcinoma. And remember, exposure to arsenics or exposure to radiation in general is also another possible cause or risk factor of squamous cell carcinoma when we get to it shortly, okay? So we finished with superficial type. The last type of basal cell carcinoma, it is pigmented basal cell carcinoma. Now from the name, pigmented basal cell carcinoma means you will have a papule, and this papule is very pigmented. It is a darkish brown. It could be whatever you want. It could be a darkish brown papule, a pinkish color papule, a black color papule, whichever color. But from the name pigmented, you will have the presence of a pigmented papule. Let's say we have a dark brown papule, right? Like in this picture right here. And it's found in the arms or in the legs or in the trunk, okay? So we have a papule here, a darkish brownish papule that unfortunately resembles not eczema, not a scar, it resembles melanoma. It resembles certain types of melanoma, like nodular melanoma, or it resembles certain types of dysplastic nevi. Dysplastic nevus basically means, or dysplastic nevi, it means a benign collection of abnormal melanocytes. Melanocytes that have become abnormal in their appearance, and they have a predisposition to eventually evolve into malignant melanocytes. And that's the problem with also pigmented basal cell carcinoma. You might see in this patient a black mole, and you're not sure whether this is pigmented basal cell carcinoma, or is it melanoma, or is it dysplastic nevus. So what do? Again, take a biopsy. Take a biopsy and you'll figure it out. And regardless, whichever type of cancer, you will treat it, right? In order to prevent further complications, right? So that's how you distinguish between the three. And that's like I said before, a lot of the diagnosis when it comes to skin cancer, it is not just clinical. There's a lot of similarity between dermatological diseases and cancer. So in order to be sure this is a malignancy or a specific type of malignancy in the skin, you have to diagnose it clinically, plus take biopsy, all right? Plus also history, but typically biopsy, okay? So that's for the pigmented basal cell carcinoma. Those are the 4 subtypes of basal cell carcinoma. We have nodular basal cell carcinoma, morphiform basal cell carcinoma, superficial, and finally pigmented basal cell carcinoma. Which of the following is the most common? Nodular basal cell carcinoma. Which of the following has the greatest extensive spread in regards to the skin? Morphiform basal cell carcinoma. Which of the following resembles dermatitis in appearance? Superficial basal cell carcinoma. Which of the following is associated with exposure to arsenics and radiation or imaging? Superficial basal cell carcinoma. Which of the following mimics melanoma or dysplastic nevi in its appearance with a pigmented papule? Pigmented basal cell carcinoma. Okay? That's what we want to know in all of them, okay? And regardless, the thing about basal cell carcinoma, the good thing is, again, the prognosis is very, very good in basal cell carcinoma, relatively speaking, when you compare it to the other types. Why? Because the mortality rate is low. And if you look at the metastatic rate, the chance of metastasis occurring, if you look at the metastatic rate in basal cell carcinoma BCC, it is 0.025%. That is way lower than when you compare the metastatic rate in squamous cell carcinoma. For example, if you have squamous cell carcinoma, even if it was small, it is 1 to 2% chance of occurring. And if you have a squamous cell carcinoma, a tumor or a nodule that's more than 4 cm, look how much it raises, up to 20%. So that's the good thing about basal cell carcinoma. We still have to treat it, but the prognosis is very good. We finished with basal cell carcinoma. Now, let's go to other types of skin cancer, and that is squamous cell carcinoma. Now, squamous cell carcinoma originates, like we said, from the keratinocytes, or the squamous cells in the spinous layer. And the squamous cell carcinoma, the clinical presentation is in the form of a slow-growing lump, Alright? You basically have a lump that slowly grows in its size. It takes over a couple of weeks to months to years. So this patient may come to you with a lesion, a skin lesion that's in his face. Characteristically, the most common site in squamous cell is the lower lip. So we talked about the basal cell being in the tip of the nose, where in squamous cell it's typically in the lower lip. It can be found in other sites as well, like the cheeks, like the upper eyelid, anywhere else. But typically one characteristic feature we could see it could be in the form of the lower lip or on the cheeks. And what is the lesion at hand in squamous cell carcinoma? What does it look like? Well, it is basically a lump in the form of a nodule, or it could take the form of a fungus-like shape, fungoid. It looks fungoid in appearance, or nodular, commonly nodular appearance. And in some cases, it could undergo ulceration. You could see the presence of an ulcer, especially in the lower lip. So if a patient comes to you with an ulcer on the lower lip, you as a dermatologist might think squamous cell carcinoma as your differential diagnosis. To be sure of it 100%, take a biopsy and look under a microscope. See what you got there, okay? So this is basically the clinical presentation. It could be form of an ulcer, maybe in the lower lip or in the cheeks. Could be a nodule that's slowly growing in general. Could be a form of a fungoid, okay? So that's going to be very important as well. And the causes for squamous cell carcinoma, we mentioned it before, is also resembles most of the same causes in superficial basal cell carcinoma. In squamous cell carcinoma, the causes could be exposure to ultraviolet rays for long periods of time, for example, or not long periods of time, let's say exposure to ultraviolet radiation in high amounts in general. Or it could be exposure to arsenics for A. Or it could be exposure to, for example, a patient may be immunosuppressive. Let's say an eye. Let's say a patient did organ transplantation. For some reason, he might also have a risk of squamous cell carcinoma. And then there is other types as well that I kind of forgot, to be honest. But there's other causes as well in regard to squamous cell carcinoma. Really, a lot of it is just associated with exposure to ultraviolet rays, exposure to arsenics, exposure to, or not exposure, patient being immunosuppressive. We don't mean people with diabetes, you mean people who did organ transplantation, for example. Or let's say also another cause as well, the S for scars. Maybe if a patient has a chronic scar, let's say in cases of osteomyelitis or trauma, for some reason these are liable to development of squamous cell carcinoma. Okay? So these are some extra causes you could keep in mind as well. Now, before we go to the last one in melanoma, I just want you to remember, when you ask yourself why is the epidermis the most common site affected? Why are we focusing on the three types of skin cancer from the epidermis? Well, they're the most common. So why is the epidermis, where all of these skin cancers originate from, why is the epidermis the one most affected? Well, if you know the epidermis, the layer of the skin, that's the one that has the highest cellular turnover. Constantly you're losing skin cells that are dead. You're constantly shedding them every day. And constantly these basal cells have to proliferate hundreds up to thousands of skin cells, right? So every month you basically have a new skin, all right? And that's why with this high cellular turnover, you are more prone to having skin cancer being developed. Not just that. Also, your skin is the one that's exposed to the environment. Your skin is the largest organ that's exposed to your external environment, and that's the one that exposed to the ultraviolet rays from the sun, and that's why the epidermis is the most common site affected, and that's the one where skin cancers, 99% of them really, originate from, right? They originate from the epidermis. So that's why I just want to go into it before I talk about melanoma, why epidermis is the most common site affected, and why are those three the most infamous type of skin cancers you will see in your career. So now let's talk about melanoma. Now regarding melanoma, this is a malignant lesion of the skin. It is malignancy of the skin in which the tumor arises from malignant melanocytes in the basal cell layer of the epidermis. So you have these abnormal melanocytes that constantly proliferate without any cause. And the risk factors for melanoma is more infamously is a case of multiple nevi. Remember what I mentioned about nevi before? Nevi means a benign collection of melanocytes. So let's see these melanocytes. Let's say we have a multiple numbers of nevi. Patient comes to you, he comes with a mole here, mole here, mole here, mole here. He has multiple collections of nevi. And let's say they undergo dysplasia. They become abnormal in their appearance. Dysplasia means the cells become abnormal. They start to, as if they're midway in their transformation to undergo malignancy or malignancy transformation. So let's say some of this nevi undergoes dysplasia and they become dysplastic nevi. Well, the problem is when a person has multiple nevi or multiple black moles, and let's say that these nevi are dysplastic in nature, they are very, very prone, really a high chance of being developed into melanoma, developed into malignancy. So that's the thing about melanoma as well. And if you have a family history of melanoma, again, there's another risk factor for developing melanoma. And for example, if you're exposed to ultraviolet rays for a long period of time, we're talking being outside in the sun for a long, long period of time. Every day you're outside the sun without tanning your skin, you're more than liable to develop melanoma, especially if you're a Caucasian, especially if you are an elderly Caucasian, all right? So that's the risk factors in general with melanoma, but the cause is typically exposure to ultraviolet rays for a long period of time, could eventually damage the melanocytes and force them to undergo really abnormality, a malignancy, okay? So what is the clinical presentation of melanoma? Well, a patient will come to you with a black mole. The thing about melanoma is that typically a patient comes to you with a black mole, but it's not malignancy yet. It is a nevi, it is benign. So the idea is still you will treat it and prevent it from progressing into melanoma. Because remember, what's bad about melanoma? It is the least prevalent of the 3 types of skin cancers, but it has the highest mortality rate when compared to the other 2 types. And really, one of the worst things you could really have is it doesn't really have a good prognosis, unlike something like basal cell carcinoma. So regarding melanoma, what is the clinical presentation of, let's say, a full melanoma? Well, let's say this patient has a black mole, like this one. Let's say this patient has a black mole, and let's say I am suspicious that this might be a case of melanoma. Then in that case, I will follow the following letters: A, B, C, D, E. A stands for asymmetry. I will see this black mole. Is it asymmetrical? Meaning, are they basically asymmetrical in its shape, in its color? So some of the mole, some of it is darker than the other, let's say. And some of the shape is basically not the same as the other. So you can have this shape, you can have a shape that's bigger, a shape that's smaller, and then you can draw a line. You can draw a cross here. You can draw a cross here, and you will see, wait a minute, this one is not symmetrical like this one, in its shape. And this one is not symmetrical to this one in terms of its color. So you can have this lesion, this pigmented papule, because that's what it is. It's a very pigmented papule, blackish in color or darkish in color. You assess its symmetry. You do a cross right at the center of this lesion, and you see, wait a minute, there is no symmetry in regards to its shape and in regards to its color. Some is darker than the other, some of its shape is different than the other, okay? So A for asymmetry. B stands for border. The melanoma, the borders are irregular. They tend to be irregular in nature. C stands for color. The color can be actually anything. But most importantly, they're pigmented. They can be anything. Black, red, well, not red, let's say black, tan, brown. They can be any color you want. But more commonly, the one people associate with melanoma is blackish in color. So the color is also important. And typically also, to keep in mind as well, melanoma has a variety of color. Yani you will not be black all the way. Some may be black, some may be pale, some may be another color, like that. It will not be a rainbow, but you will see a difference in color. Okay? So that's what C stands for. And D stands for diameter. If you have a pigmented papule and it is more than 6 millimeter, that is basically the size of a pencil eraser, then this is also another sign of a full melanoma. So D is for diameter. If it's more than 6 millimeter, or let's say 6 nanometer, let's say, regardless, the size of a pencil eraser, then this is another indicative sign of melanoma. And the last one is E. E is for evolving, evolution. What does that mean? It means that, for example, if a patient has a dysplastic nevi, it changes its appearance, and now it starts to resemble more and more of a melanoma. So you basically have a patient, and this patient tells you from his history, this black mole, it wasn't like this 3 months ago. 3 months ago, its appearance was changing, and I don't know why. So that's what's meant by E for evolving, is that this lesion evolves, and this is another sign that indicates full melanoma. So in regards to melanoma, in a person who has melanoma 100%, full melanoma, he will have all of the features, okay? He'll have A, B, C, D, E. Asymmetry, irregular borders, different variety of colors, diameter more than 6 millimeters or 6 nanometers, and E is evolved. It has evolved in its appearance across the month's duration, okay? However, in a case of nevi, let's say let's say we have a black mole, and let's say this patient has maybe just 2 features. He only has A and B, right? He has asymmetry and irregular borders. Does that mean I can exclude melanoma and that's it? No! If a person has A and B, then this can be seen, especially in people with dysplastic nevi, or really nevi in general. So the purpose of this A, B, C, D, and E, when raising suspicion of a black mole, the purpose of this is that when you're suspicious of a mole and you confirm that this mole has some of these features, you can prevent the progression of this mole from developing into melanoma. So even if you don't have all of the features in a full melanoma, if a mole has 2 of these features, then you can treat it before it develops into a full melanoma. Okay? So that's the idea behind it. And typically, where will you find these pigmented papules? That's the skin lesion you found in melanoma. Will you find these pigmented papules? Naturally in sun-exposed areas. Any part of the skin exposed to the sun, again to ultraviolet rays, you'll find the pigmented papule in melanoma. But you can also find it in non-sun exposed areas. Areas of the skin that's not exposed in the sun, or areas of the skin not exposed to the sun. You'll find that as well, especially in the buttocks, for example. Alright? So you mostly find it in sun-exposed areas, but you can also find it in non-sun exposed areas. It doesn't make a difference, but you find it especially in sun-exposed areas. So we finished with melanoma. Now the last thing to end this video is diagnosis and treatment. You see, the diagnosis and the treatment in concept, it is the same. It is the same for all the types of skin cancers we've talked about. Regarding diagnosis for any type of skin cancer, again, clinical diagnosis plus biopsy. I could take a shave or punch biopsy. You can look at other videos talking about the procedures in dermatology. What do I mean by shave and punch biopsy? But biopsy is the key. In case of squamous cell carcinoma and basal cell carcinoma, you can take a punch biopsy, take enough tissue sample, put it under a microscope, and see what you got. And in the case of melanoma, if you're suspecting melanoma, take an excisional biopsy. Take the whole lesion, take the entire lesion, put it under a microscope, and you will see whether this is melanoma or not, for example. And regarding to treatment, the treatment here is surgery. And this depends on what type of surgery you want. Like for example, in the case of basal cell carcinoma and squamous cell carcinoma, the types of surgery can be excision. You can just remove the lesion. You can just directly remove the lesion. Or you can do electrodesiccation, use electricity to remove the lesion. Or you can do chirotherapy. Chirotherapy can be indicated like in squamous cell carcinoma and can be indicated in superficial basal cell carcinoma as well. So what about melanoma? In melanoma, can I do chirotherapy? Can I do electrodesiccation or whatever? No. In melanoma, the treatment is simple. You'll do excision immediately, and the amount you will remove is according to the size of the tumor or the size of the lesion. If it's like 6 millimeter, I'll remove more than 6 millimeter just to be sure it's completely removed. So in the case of melanoma, you'll do excision. You remove the tumor directly, and since melanoma has a high chance of metastasis, you will also do chemotherapy if there's extensive tissue involvement as well. Okay? So you have a variety of options regarding treatment in basal cell and squamous cell, but in melanoma, it's straight up excision. Same goes for biopsy. You'll do excisional biopsy in case of melanoma. But in the case of squamous cell or basal cell carcinoma, You can do punch biopsy or shave biopsy. The most important part is you just get enough. There's also different variety of diagnostic methods, but these are the most important ones or the most common ones to know. Alright? That's pretty much it for the skin cancer lecture and the really malignant skin lesions in general. Thank you.